This conference will now be recorded.
Hey everyone, it's June 10th, 2025, and it's AnCan's High Risk Metastatic Advanced Prostate Cancer Discussion and Support Group. We're here to some extent due to support from Bayer, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis. And thank you to them. We usually start out by introducing the new people and getting a little history. So I guess we will do that tonight. Now, DJ and Daphne, can we start with you?
Sure.
Okay.
So can I just say a couple of words, John?
Oh yeah, sure. I can start the card up.
The reason we were worried is because our Alexa Jet, who is the oil that lubricates everything and gets us here, and she does everything behind the scenes. Her ma works at University of Texas, and when Biden was diagnosed recently, the announcement, she went around telling people they needed to get PSA tested, and it turned out that 3 of the people that she told, I don't know how many people she went to get tested, but 3 of them were de novo metastatic. I raise that because it's very, very significant in terms of what we're seeing everywhere and what we see here. A lot of our men come in now, sadly, de novo metastatic. We were worried that all 3 would show up tonight. I don't think we got any of them, but we'll be welcoming them over the next few weeks or months, I'm sure. I will let Dr. John get on. I just want to make other comments since I know some of you read the active surveiller. I just want to assure you that nothing we say or do or recommend in this group is in any way, shape, or form influenced by the sponsorship money we receive from pharma, which is what the so-called Dr. Forsman alleged. It's not true. So just know we're unbiased here, and we call it as we see it. Sometimes that's good for the pharmaceutical companies. Sometimes it's not so good for the pharmaceutical companies. We'll take our shots as we get them.
Okay, so let me find Jack and Daphne on my screen here because I got so many. Where'd you go? Oh, there you are. Okay. Okay, so how old, Jack?
71.
And where do you live?
I live in Saugatuck, a little bit south of Saugatuck, Michigan.
Okay. Now, with the new people, this is optional, but we like to get a little background history to help us know how to help you answer your questions and share experiences with you. So, can you go back in time a little bit and tell us about when you got diagnosed and why?
Well, I'm right now undergoing chemo. I got a little bit of brain fog going on, so I'm going to hand that over to my wife, who has really been my
Okay.
caregiver and really knows all the ins and outs and facts of my case. So that's okay.
That's great. Yeah, we welcome anybody's spouses, significant others. So, when was Jack diagnosed, Daphne?
So 2008 at 54 years old.
Oh,
And it was a PSA of 5.6.
yeah.
Biopsy had 10 cores, 4 were positive, mostly Gleason 6. I'll just keep going through the history unless you want to know something. And
Yeah,
then
let me just stop you there. When you said
yep.
mostly Gleason 6, were there some 7s or 8s or?
Well, I don't have that note. I mean, this was 2008, so it was,
Okay,
a
so
little
as
bit.
far as we know, back then he was originally diagnosed with Gleason 6.
He had a prostatectomy 2 months later, and then it was a Gleason 7.
Oh, okay. They upped him to a
Yeah,
7. 3 plus 4, 4 plus 3.
+3.
What?
No, 4 + 3.
4 plus 3. Okay.
0 of 4 lymph glands had anything. There was a perineural invasion and an extracapsular extension. And at that time, I'm kind of a bulldog, and so we sent the pathology to Dr. Epstein, who said that it was crushed and it was through the ink, so it was hard to tell, but he suspected it was non-focal.
And he agreed with that 4 plus 3 pathological diagnosis?
Yes.
Very good. Then what happened?
17 years went by.
With no PSA? Or?
Well, the nadir came down to less than 0.01, and it stayed that way until I was about 0.02 in 2013, 2018, 0.05, slowly creeping to 0.015 in 22, and then he got COVID, a bad case, and then November 23, it was 0.198, and last August it was 0.36, and then in November it was 0.43, and we asked for imaging. Had an MRI with contrast, and everything was clear. So
This
then
was
we,
late last year, right?
yes, late last year. And so this was all through our local urologist.
Okay.
So then we asked for, when is it time to see an oncologist or have more imaging? And I had read about a PET scan, and so we were able to find a oncologist to get a PET scan in January of this year. And the PET scan showed 3 1 centimeter nodules in the right upper, middle, and lower lobes of his lungs. No other PSMA uptake. So a lung only presentation.
That MRI must have just been a pelvic MRI then, huh?
Yes, yes.
So it missed the lung metastases. Okay.
Yep.
Okay.
So then we had a bronchoscopy, a very expensive procedure, by the way. And they were unclear findings. They said they didn't get enough samples, so they had a tumor board meet, and then all of a sudden they said, well, what was insufficient we now believe is sufficient. We believe it's from the prostate. So that was just a little wishy-washy. So we made an appointment at Mayo Clinic to try to dig deeper into what, if we had a primary lung cancer or what we had going on. And so we went there, and we were originally scheduled to see an oncologist there, and then our local urologist knew Dr. Kwan at Mayo, and so he recommended we see him. So that's who we ended up seeing, and he ordered a needle biopsy of the lung while we were there. And the needle biopsy was successful, and they found adenocarcinoma of prostate origin.
Okay.
So then what do we do? So Dr. Kwan recommended, they did a PET scan, they did all that there also, and he recommended bigger therapy than what our local oncologist had been suggesting.
Okay, we're happy with that.
He recommended what we call quad therapy in our household. So he was adding carboplatin to the triple therapy. And
Carboplat. Okay.
so then our local oncologist wasn't comfortable with all four at once, and he said, yes, he can understand the PSA now is 0.36 at this time. So he said with the low PSA and the odd presentation in the lungs, he could understand wanting to be more aggressive. And he said we could do the docetaxel and the carboplatin. We'll start with that and ADT. And then after the 6 rounds of that chemo, that double chemo, we would do the ADT plus an ARPI, Nubeca or abiraterone. So the people at Mayo said, yeah, okay, we can sounds okay with us. So anyway, we've been through, he's had 2 shots of Firmagon and 3 rounds of the double chemo. And this round, which was last Thursday, hit really hard. I understand that they adjust the carboplatin according to your creatinine levels. And he had 25% more of carboplatin this last time. And whether his kidneys can handle it or not, it really hit hard. And so we're just kind of questioning going forward. We were happy to finally have a treatment plan and stay with it. And now we're sort of questioning, is this overkill? Do we just finish the 6 rounds? We're scheduled to go to Mayo on Sunday for another scan, 2 scans and lab work. And I've tried to get an appointment there with an oncologist there for another opinion, and I'm not sure if that's going to work out or not. So that's where we are.
So which doctor is actually your main medical oncologist at this moment?
At this moment, it's a Dr. Emerson Lim in Grand Rapids, Michigan.
And is that a GU medical oncologist?
Genitourinary, yes. He came from Sloan Kettering.
Okay.
We like him. He's humble. He didn't have a problem with us going to Mayo. Of course, why would he?
Yeah.
And so it feels a little awkward to think about a different oncologist, but it's sort of feeling like, are we doing more than we really need to do? Because it seemed like a slow growth kind of a thing. And we've also had a chromogranin, at my request, the chromogranin A test that came back normal, or 86 according to the parameters that they use. We've had a germline.
Oh, that's what I was going to ask. Good, yeah.
And nothing came up there, although Jack has 10 brothers and 4 of them have prostate cancer, and his father had prostate cancer, and an uncle. So that's interesting, but there was nothing that came up in the germline testing. He also had somatic or liquid biopsy, and nothing came up except mutation. There were low burden and there were some mutations, but they weren't necessarily related. But NF1, he did have a mutation there, which I understand is a suppressor gene, but it's not necessarily related to prostate cancer.
Right. So the liquid biopsy came up with the NF1. The germline test, despite a very strong family history in the male line, came back entirely negative.
Yeah.
And we don't really have a somatic biopsy. They did get a piece of that lung tissue, though. Did they test that for genes?
Yeah, I asked Dr. Kwan's team, are we testing that further? And they said, no, there will be no more testing. And it was kind of like a blunt, there was no explanation. So that's my question for him when I go back. Why? We're talking about my attitude here. Sorry if I have a little attitude, is we're talking about aggressively attacking what's called a sneaky cancer, but we haven't identified what the sneaky is.
Right.
I don't know if that's unrealistic or.
Daphne, I think we endorse your attitude in this group. I think everybody would give you a thumbs up. In fact, a few of you guys need to go down to that React and start giving Daphne her dues. There, here they come. Here they come. Here they come. I spoke with Daphne earlier on today, and I gave her some ideas in the event that we couldn't get to her today. So let me just shortcut that, and then we can take the hands up. And
Thank you.
as you all know, we're not big fans of Eugene Kwan acting in the space of advanced prostate cancer, and this is a good example why. There is no good. My question to Kwan, if you see him, is why on earth are you going overboard on this? We've seen a lot of guys, and I'm sure there's some guys in this group now who have had nodules in their lungs, and we've addressed them very easily without going over the top. When nodules appear first time, and maybe Ben knows more about this, but when they appear first time in the lungs, tends to be a not so aggressive cancer. Not always, but it tends to be. I don't know the reasons why, but I know that I've read that's what I've observed. We suggest that I shouldn't say we because it was really me, but I think everybody endorsed. We'd like to see Jack and Daphne tie up with a really strong GU medical oncologist to work with Dr. Lim locally. And I've given her two names. One is Elizabeth Heath at Mayo, who doesn't have an easy time working with patients that come from Quan, but I think we can make. I think Daphne can make that happen. The other alternative would be a little closer to her, would be Dr. Szmulewitz. So why don't
I called Liao this afternoon to try to get an appointment with Dr. Heath, and it was a little jumpy because we have appointments scheduled, but I did get an appointment for June 23rd, but it was very awkward. I'm sure she wants all the tests that we're supposed to go for Sunday, so I'm hoping that they'll look at it again and see if there's anything closer or move all the tests and go to her. I don't know. It's kind of awkward.
How far apart are the carboplatin treatments?
3 weeks.
So do we have 3 weeks from the last one
Yep.
before you see Dr. Heath? Okay. Well, I'm glad that you're going to do that. So right now we've got docetaxel, Firmagon, and carboplatin. What was you said there was 4.
The Nubeca was recommended, but our local oncologist doesn't want to do all 4 at once.
Oh, you're waiting so that's the 4th
The
one.
RP will come after the
Yeah.
3 more rounds.
Okay. And there has never been any radiation of any sort, right?
Never.
Okay.
And the nodules, so I had asked about SBRT, thinking at that time it was an oligo situation, but I realize now with all there's the whole seeds that I didn't understand before. So I understand.
No, it is still an oligo situation. There are 3 lung mets and no other mets anywhere else.
Well, apparently there are a lot of micronodules in the lung also. So I don't know if that counts, but all the nodules are along the vessels, the major vessels in the midline.
How about sending us the PET scan report?
Okay.
Because you can email it to me or Rick, and that way we can get a little
not
idea.
to me. You can email it to Dr. John, please.
Put my address in there, would
I
you, Rick?
will. I'm doing it right now. John, I'd suggest we get around because we've got so many people who have questions. Let's get around the people who have their hands up.
Right. That'll help us, Daphne, to look at whether this is in fact an oligo situation or not. And your main question is going to be, do we really have to hit him with carboplatin and obliterate him like this, or is it sufficient without? Okay, let me see who's got their hands up. Jack does.
Yeah, I just, I know Dr. Kwan, and I just wonder to what degree he in his head somehow or other, in spite of the biopsy showing up as adenocarcinoma, whether he had some theory that maybe it wasn't adenocarcinoma because he hits you so hard as if there was some other, variant operating in the lung. Did he say anything about that to you or not?
Yes, he didn't give any definitive answer about what. He just said he thinks it's a sneaky cancer.
A sneaky cancer. That's what he said. Does that
Uh,
mean
it's,
slow,
it's,
indolent, or
I
something
don't
else?
know. My question is, I need something more definitive than sneaky.
well,
Yeah.
it sat there disguising itself as a 3+3 cancer for a great many years, and then suddenly started acting like an aggressive cancer. So
After some,
either it was a new cancer, or a new mutation, or it was a lung cancer. That's probably what he meant. But what Jack means is that for him to react so aggressively, something must have prompted it. So maybe we should look at the brush biopsy report from the bronchoscopy as well. Yeah, good point, Jack.
Just remember having the same feeling when I saw him in 2018. From the get-go, he went right for the, chromogranin A and CEA and all these other things, speculating the possibility of a de novo NE. So, some people are just inclined to go that way for whatever reason.
Steve?
Maybe they missed the diagnosis somewhere along the line, and they just want
Yeah,
to make sure it doesn't happen again.
don't want to do that again.
Yeah.
Steve, you got a comment?
I just wanted to throw in my opinion of Dr. Heath was fantastic. When I first came to this group, AnCan, I discovered I was probably not getting the right treatment I was supposed to be getting, prescribed from a medical oncologist here locally in Traverse City, and I was advised to seek Dr. Heath's advice. And I honestly can say today that she, her bedside manner was awesome, and I finally got a great perspective of exactly where I was. She changed the procedure that I was getting, the medications, and I really believe to this day that she probably added years to my life, and I really love her. At that time, she was at Carmenos and down in Detroit. So I hope and I pray for you guys that you can get in to see Dr. Heath. That's all.
thank you.
Anybody else? Ben?
No
I
longer
didn't
being
have anything to
recorded.
say.
This
I'm sorry.
conference will now be recorded.
I turned off the recording instead of turning on the mic. Oh God.
You tell
It's
he's
so glad
also
I
a
joined this call.
mono.
I wanted to say that I have lung-only mets, and that the prognosis for lung-only mets is good to very good. A recent study showed that it was the best prognosis of all mets. Can send you, I could send you the study. It was very heartening, and there was an earlier one that showed it just behind lymph nodes as better than any prognosis, lung-only.
And I just like to say thank you, Ben, because I thought I'd read it, but I wasn't sure, but I knew you'd know. And I just want to do a quick acknowledgement. We didn't do it at the beginning, but we have 4 moderators on here tonight. We haven't had 4 moderators in a long time. Dr. John, Ben Nathanson, Len Sierra, and myself.
So, cognitive brain difficulties. What else we got? What else are we suffering from right now? Pain anywhere?
Are you asking us?
Yes.
I would say he's really tolerated it surprisingly well until this time, and it was mostly fatigue. Um, he's had a lot of leg pain, but he has an arthritic hip that he was going to have replaced before we discovered this.
Oh,
So that's kind of a big nuisance. Um,
and there's pain in that hip.
yes, and down the leg.
Okay.
Like nervous leg syndrome. I don't know, or I think that's what they call it, or
Yeah, restless leg syndrome.
restless leg. Yeah, I had that earlier on, pretty bad. Right, wouldn't let me sleep.
Right
But
after the chemo.
just recently, that seems to have abated a bit, and so now it's just like mainly hip pain and leg pain.
Okay. Well, yeah, continue to get after that hip pain for your quality of life and just make sure for us that there's nothing going on in the hip bone
Right.
related to prostate cancer. Um, I would love to take a look at the biopsy report that they got from the bronchoscopy and just make sure there wasn't some type of small cell or neuroendocrine transformation in the cancer that prompted this carboplatin. And we'd love to look at the PET scan and clarify how many metastases there are and whether to even think about radiation or deal purely with whole body therapy. Um, and welcome to group. Anybody else have anything they'd like to say, or do you guys have any more questions you'd like to raise? Okay, we meet almost every week. Rick has probably already educated you about our schedule, and we're glad to have you.
Thank you very much. We're happy to know about you. We just found out about you yesterday.
Okay, so let's see. Um, is George a new guy, Rick?
I
George,
would say,
George Diaz. We already
so.
have it. Go ahead.
Okay. I would say he's not new to me. He's not new to you. He's new to the group. He's not new to Ben because Ben's been doing a great job mentoring him. So, what I would suggest in the interest of time is that you give a summary from last night from your notes rather than us going through the whole interview. And that will save a little bit of time. And then we can have some time to talk about George's situation and hear Ben's thoughts.
Well, I'm in trouble, Rick, because I've got only one screen now instead of my usual two. I put that stuff in. I think I put that stuff in LGL. I don't have a card on George.
Okay.
I can be very brief.
You want to give us a 3-minute summary so everybody knows who you are? And I apologize for not having your history at my
It'll be
fingertips.
my pleasure. First of all, I want to thank Rick and Ben for all the help they've given me. I'm a newbie at this. I was diagnosed about 5 weeks ago with intraductal. I've had an MRI. This was all prompted by the velocity of my PSA. I had an MRI. I had a biopsy. That biopsy was corroborated by Epstein. I will be having a PSMA at the end of the week. I'm at Northwestern in Chicago. I saw two individuals. They both recommended surgery, nothing else, pretty much. And I was not really happy with that because I felt I was not getting any options really. So I will be seeing Healthand in a week, but I most likely will be moving to the University of Chicago with Eggner and his group. That's pretty much where I am. I'm not opposed to surgery if that is my only option. but at the very least, I want to sort of have before me what my options are so that I can decide. Um, so that's pretty much overall my picture, really.
Okay. Well, thank you. That was very concise. Very
And
good.
and your age?
I'm
George?
70 and healthy otherwise. In other words, I don't have any other issues. So that's where I am. I'm
We
happy to.
moderators have been really interested in following George and answering these questions because we have not run across somebody with intraductal cancer in the absence of adenocarcinoma. And so we have questions about efficacy of ADT, of radiation, of surgery, and the path forward.
So I wanted to add one thing, that just one of 12 cores was positive. And it was not all cancer, right? Parts of it were cancer. It was definitely intraductal. But as John just said, there was no evidence of other kinds of cancer. Intraductal is kind of peculiar because it's technically not an invasive cancer. So it's very, there is some indication that it's not responsive. There are good reasons why it would not be responsive to radiation. And the radon himself at Northwestern, I think you said, George,
Yeah.
suggested against it.
Yeah.
Correct.
And,
Thank you, Ben.
and can we also add that Ben knows, because he's a peer, you had intraductal yourself, did you not, Ben?
So I have ductal, but it has it appears intraductally as well.
Okay.
So it's a completely, as it happens, they're two unrelated cancers with very similar names.
Yes, different cell of origin.
Thank you.
Okay. Great. Okay, George. Have I got everybody that's brand new to the group now?
I think you may be expecting one more person to come in a little bit late. So once
David
we've got,
is raising his hand.
I have a guest coming in a little bit after 4. They were at work, and they're
Oh, are you David Keller?
yeah. This is David Keller. We're asking the
Oh,
time. Yes.
hi, David. I'm John.
Hi, John.
Okay,
Thank
I'll get on with my regulars and we'll see what happens with Ken, right? Isn't it?
That's exactly right. Thank you very much.
Okay. Great.
John, let's just see if anybody has any questions for about this IDC, since it's so unusual.
Okay.
Does anybody have any concern? Would they like to say anything about the IDC?
George?
Do we know conclusively that radiation does not work for intraductal? I mean, has
I'm
that
not
been?
prepared to say that yet.
I'm sorry?
I'm not prepared to say that yet. Anybody else?
Yeah,
Len, Ben, Rick?
Ben, you know more. You're really more of an expert on this. What's your thought on radiation and this intraductal? There you go.
I mean, that he should go to Chicago and talk to really good people.
Okay.
I mean, I could think of biological reasons, like 2 or 3 biological reasons why it wouldn't work. That it's not preposterous to claim it wouldn't work, but that's not a medical diagnosis.
Thank you.
Yeah, I mean, I think this is the reason why we've sort of directed you to this team of Eggner, Stanley Liao, and Russell Szmulewitz, because I think you're going to get the best combined opinion from the 3 of them.
And I will go that route.
Jeff, what do you got?
Yeah, at the forum, that UCSF thing where they discussed cribriform a lot, they did say that if you have intraductal, it's very likely you have cribriform, which is worse than intraductal actually, but it's pretty easy to tell. It's just if the cells have a whole bunch of holes in them, they have cribriform.
It's pretty easy to tell if you have any adenocarcinoma to look at, which we don't. It's kind of strange. Yeah, thank you.
So this is a little mysterious. Crib reform has no Gleason. I'm sorry. Intraductal has no Gleason grade. Crib
Right.
reform has a Gleason grade of 4. Intraductal plus crib reform, Jeff is quite right. They show up together often. Would, I believe, have to have a grade of 4, and Epstein concurred that there was no Gleason grade. So presumably it's not crib reform, for what that's worth.
Yeah, they
Now,
actually said during the event that it raises it to a 5. Even if you have a 7, it gives you 1 5. A crib reform.
Well, no, crib reform gives you a 4, unless I think it was automatically gives you a 4, but it can also raise a grade from a 4 to a 5. But if you see crib reform,
If over 0.25 millimeters,
right, so
that
it's
was
it's got to qualify it. Now, the
right.
most interesting thing that comes to my mind about this pathology, and I think this came from Dr. Zhou, is that he has never seen generally surgery is the preferred treatment for crib reform. And Zhao said he's never seen an intraductal alone when the prostate has been taken out. There's always been some adenocarcinoma somewhere in that prostate. Of course, the only way we can know that is to remove the prostate. So whilst we don't see any, doesn't mean that George doesn't have any. And most likely, if he were to have his prostate removed, there would be some in there.
okay, very good. Keegan and David, I'll get to you in a little bit. I'm going to get to a couple of our regulars and get you in about 4 o'clock. Is that all right?
I don't think they're here yet, John, are they?
Keegan is here. At
Yes,
least
I'm here, and Keegan is trying to find her image on the gallery screen.
All right.
Oh, she said, okay, now she sees. Oh, now she disappeared. Okay, so we're working on that. Thank you. Go ahead with another person.
Is Matt here? Matt M?
No.
We left him off last week, and Rick and I wanted to make sure to get to him. Stephen,
There are.
what would you like to discuss tonight?
Thank you, John. I guess I'd like to give a quick review of my situation. I'm 69 years old. I was diagnosed in February of this year with a Gleason score of 4+5. I'm in the process of choosing an initial treatment. And so far, I've seen 2 sets of doctors, one at Froedtert and the Medical College in Milwaukee, and the other at the Carbone Cancer Center at the University of Madison in Wisconsin. And I've begun seeing a 3rd set at the University of Chicago. Yesterday, I saw Dr. Liao, and Friday, I'll see Drs. Eggner and Szmulewitz. And I was wondering if anybody in the room has been treated by any of these doctors and would be willing to connect with me outside the group. And I've already been in contact with one, John M. And he's outside Chicago. We're already connecting. So that's what I'd like to bring up this evening. Thank you.
Okay, say those names for us once again. Eggner, Szmulewitz,
And the 3rd one is Liao.
and Liao. Anybody here would like to share their experience with any of these doctors?
Okay, so we will connect you. You can reach out to David M. at AnCan.org. I'll put that in the chat window for you, who has been with Dr. Szmulewitz for a long time. I would say just there. I don't want to give you more, but talk to David M. David he's not on tonight. He is one of our board members. I think he'd be happy to talk to you. Just tell him that you were referred from the group to talk to him about Dr. Szmulewitz. Dr. Eggner is a little tough for us in this group because most of the guys are not close to surgery. And so it's pot luck if they had Dr. Eggner originally or not. He does a lot more with our active surveillance folks and our low intermediate. So I would say start with David, and if I can think of anybody I can connect you to for Eggner, we'll go for it. Oh, look, John Maxwell's waving his hand. I know he saw Liao for a thing. Go ahead, Mr. Maxwell.
So I'm under the treatment of Dr. Szmulewitz, and I think he's outstanding. I'm very happy with that. I met with Dr. Eggner, and I thought he was brilliant. I decided not to do a prostatectomy. I went with brachytherapy instead, so I didn't use him. But I was very impressed with him, and my radiation oncologist trained under Stanley Liao, who I didn't get a chance to meet yet, but I met several of Stanley Liao's team. Those three guys are the A team. If you're meeting with those three guys, I think they're as good as anybody in Chicago. But I've got a limited experience, but I like them all.
Thank you.
Stephen, would you mind giving me your last name for my records?
Sure, I'll put it in the chat.
Okay, you can send it personally to me, or just so I can.
I have it, John. I have it. Just remind me and I'll give it to you.
Okay.
Thank you, everyone.
You're welcome. Tony Fig, still here?
Yes, I just wanted to give an update. I've had been in remission for 2 years, and 3 months ago, it went from undetectable to 0.2, and this week it went to 0.4, so it's up in 3 weeks or 3 months. And another interesting thing is my testosterone 6 months ago was 652. 3 months ago, it dropped to 547, and now it dropped to 476. So I don't know why that would be dropping like that.
Particularly as you're apparently recurring, your testosterone's going down.
Yes. Yep. And another thing in the blood work, it showed the granulocytes has gone from 0 to 0.1, which they say is very high. So I'm not familiar with what that is. I think it's inflammation, and it could be maybe from the hip replacement I had 2 months ago.
Okay. Well, I'm sorry to hear that you're having a biochemical recurrence. I think at 0.2 we maybe could call it that. Is that what we're going to do?
I think it's higher, isn't it?
0.2, from undetectable to 0.2, and then 0.4.
That's right, yeah. I think it's 0.4, John.
And it's 0.4, so we're comfortable calling it a recurrence rather than a blip. Is that fair to say?
I've got an appointment with the oncologist on Monday.
Okay. Had you guys talked ever about what are we going to do when my PSA comes up again?
No.
Okay. What are you expecting then? Tell us about what you're expecting to happen next week.
I'm thinking that we'll just wait another 3 months to see what happens, and thinking that, eventually may go back on some hormone drugs.
I'll tell you what my guy said, because I'm in a situation just like you were recently. And I said to him, well, what are we going to do when? And he said, when you get to point two, we're going to get a PET scan, and then we're going to put you back on ADT. So maybe something like that is going to happen.
Well, a PSMA PET scan really won't show anything very well until you're at around 0.5, I guess.
It might very well not. The sensitivity at lower PSAs is worse. Nevertheless, that's what he says he was going to do with me when I recurred. And we have also seen reports of radiological recurrence without biochemical recurrence. So I didn't argue the point at all. I thought I'd take it.
Yeah, and I chip in that 0.15, 0.2 is when we think you can start, and that's generally what we say here. You're going to see more at 0.5, yes, but the doctors now are generally using 0.15, 0.2 as the lower threshold. So, and for me, earlier is better, and I think there are studies that support that. And so I would be getting a PSMA scan if we have to redo it and it doesn't show anything. Fine. I mean, we don't. Have you had a PSMA scan before, Tony?
Yes, October of 22. And I talked with my doctor about another PET scan, and he's not opposed to it. As a matter of fact, he thought that if I wanted to go ahead and get one, I can after my last
if it
meeting.
were me, that's what I'd be doing. Ben, what's your thought on this one? And Len, we haven't even heard from Len. We haven't heard from Len today. He's so quiet. Len, go to you first. What's your thought first, and then we'll hear from Ben.
Well, I did put something relevant in the chat box, so I haven't been completely silent.
Okay.
But anyway, so the question is, I heard John say his doctors said when he gets to 0.2, they'll put him back on, they'll do a PET scan and put him back on hormonal therapy. And so is the question for Tony, does he do the same thing? Is that the question?
Well, the question is, I think if your PSA had gone from 0.1 to 0.4 over the course of this year, what would you be doing for yourself?
Yeah, well, same thing John mentioned. I'd get a PET scan, and after seeing the results, probably go back on hormonal therapy. Maybe even more than that, depends on what they see in the PET scan.
Yep.
So this discussion, I think, Tony, for your purposes, is to maybe move you a bit off the idea that they're going to just say, let's check it again in 3 months.
If they did suggest hormone therapy, would you go on? You'd probably go on doublet at this point.
What were you on before?
I was on Firmagon, just single.
Probably just go back on what you were on before. I don't know, because I don't remember your original risk level.
Well, I think I would say, well, let me ask Ben before what I would say, and then I'll say, Ben, what would you go on?
I think regardless of what he went on before, I would go on doublet therapy. And
right, yeah. right, and the doublet suggests that you get the most value for your money by going on abiraterone first, unless there are comorbidities that you live with that make you a bad candidate for abiraterone. And I think if that were the case, then probably darolutamide, and if you have to go on an ADT drug, the preferred ADT drug today is Orgovix, but we find some people like Ed L who can't get their insurance to cover it, so you'd have to go. If you are going to go on to another ADT drug other than Orgovix, and it's not Firmagon, it's one of the others, you got to make sure they give you a buffer first.
Is abiraterone the one that you should not take if you have some heart issues? I had a heart valve replaced last year, and I have a pacemaker.
Yep. So, your ideal would probably be Orgovix and darolutamide or Nubeqa.
Okay.
Tony, you mentioned
Thank you
something
very
about
much. Well,
you mentioned something about granulocytes being high,
Yes.
and you
Then
said
he gave very
0.1?
low numbers. Yeah.
Very low number, right?
historically it was at 0, and according to the lab, it's at 0.1, but they rate it as very high.
I think Glenn has identified a misunderstanding because you wouldn't live long with the 0 granulocytes. So if you'd like, you can actually send me or Len the lab test, and we'll
Okay.
try to answer your question.
All right.
Alan, let's go to you, and then I'll go to our new guy.
Yeah, so I just wanted to say that I was initially turned down for Orgovix, and Dr. Gainesman wrote a letter to the insurance company telling me it was necessary because of heart problems, and then they approved it.
Okay, that's helpful to know. The other thing I just to tell you is that for your testosterone to be 450 or 600, even in the same day, is not unusual. Testosterone swings around like crazy. It can be 700, 800 one day, 500 the next day. And it also depends on the time of day that you're measuring it. So I wouldn't be concerned that you're 450 and then 600, or 650 and then 450.
Thank you.
Okay. Keegan, I was picking up a lot of noise, so I muted your mic temporarily, so I'm sorry for doing that. Is Ken with you?
He is not. Can you hear me? I don't know if
Yes.
I'm.
No, we got
Okay.
it. Yep.
This is new to me. Ken
Okay.
is not well right now. He's in a lot of pain, so he's sleeping right now.
Okay. Should
So
we
you're stuck with
introduce
me.
you guys to the group anyway, and then when he's feeling better, he can join, and you can be his representative in the meantime?
Wonderful.
Okay. Okay, that would be fine. I got a little background information, but David only told me that he was over 65. How old is he?
He is 68.
Okay, and you guys live in California?
Correct. In the Palm Springs area.
Palm Springs area. Okay. And when did Ken get diagnosed? How did that come about?
Quick synopsis. In late 2017, his annual checkup showed a PSA of 3.5. So his doctor put him on a couple of rounds of antibiotic, thinking that it might be just prostatitis. And so then repeated labs in 2018 of March saw the PSA up to 5.6. So at that time, the doctor recommended an MRI, and that was done in May of 2018, and it was obviously suspicious. I don't have the copy of the report of that, but at that time, because of the suspicion, the doctor recommended we move towards a prostate biopsy. And we were set to have the old-fashioned transrectal prostate biopsy to be done in July, but the day before, my husband heard an ad. A new physician, Dr. David Schreiber, came to the desert. He developed the Euronav transperineal prostate biopsy process out there at the University of Colorado. And I don't know if he sold it to them, and he came out here to the desert and was establishing his practice and this new procedure out here in the desert. And so my husband was actually his first case here in the desert for a transperineal prostate biopsy. So
That's interesting.
he had
And
his,
then you only got a Gleason 3+3 out of that, I understand.
well, the first, he had 3 biopsies. The first 2
Oh,
just showed suspicious tissue, but no positive delineation.
oh, okay.
So Dr. Schreiber, he said, I don't want to be a bearer of bad news, but I know you have prostate cancer, because in the meantime, repeat PSAs, he went as high as 11.8 in February of 2019. And even after that, the biopsy was just suspicious. And he stayed up to in the 9.3, 9.6 range. And finally, his third transperineal prostate biopsy in February of 2020 gave us the definitive diagnosis. But yes, it was only a 3.3 for a 6 Gleason score. So the doctor started him on Casodex. We began to see a urologist as well. And then in June of 2020, he had brachytherapy seeds implanted. And that seemed to be very successful. His PSA came down to 1.5 and then 0.9. And so basically in 2021, we kind of coasted, feeling like we were in remission. His PSA never went above 1.4 the whole year. And it wasn't until his annual checkup in April of 2022 that all of a sudden his PSA was 6.5. So we got in to see the urologist again, and that was in May of 2022. And at that point in time, he felt he needed a PSMA scan. So Ken's first PSMA scan was in June of 2022. And it did show stage 4 metastatic, at that time, just 4 lesions. I think a couple of ribs, right femoral head, and one on his iliac crest, I think, on the right side. So we were referred to an oncologist at that time. And during that time, our urologist did have Ken on Casodex, and then he also did start him on Lupron. So he was starting the ADT therapy at that time. And then when we saw the oncologist in April of 2023, he kept him on the Lupron, started him also on the Zytiga, and then also began giving him Zometa for biphosphonate, strengthening of his bones. So we pretty much coasted through 2023 with that therapy. Follow-up PSMA in March of 2023 showed, I think, 6 or 8 lesions. So he had doubled the lesions despite being on pretty intensive ADT therapy. But our oncologist just kept on going with the program. I read in his note, he staged Ken's cancer as a small c, capital T, 1A, capital N0, capital M0.
Yeah.
That's
know.
not accurate though.
Yeah. That's
No,
That's not right.
not right.
no.
He made
And the
stage.
radiologist didn't agree with that. He, in fact, I took a picture. He said from the very beginning, Ken's prostate cancer has not responded typically. It has not presented typically. Um,
I think
so,
let me just. I'm concerned about time, Keegan, because
Yeah.
we have a lot of people
yes,
here.
yes, I'm
Let
sorry.
me just let me just skip through. He had Provenge in
Yes,
2025. The PSMA showed 14
2024.
hotspots and lesions. He's
Yes.
had some bone pain. The problem, he's being treated at Eisenhower. We don't have great experience from Eisenhower with their people. We've moved people before. So when we heard about this early in the week through David, Keller, he said, my first response was, we've got to get him out of there as soon as we possibly can and get him down to somebody expert. And we suggested Tanya Dorff. The doctor in Eisenhower said, oh, you can't get in to see Tanya Dorff. And we said, sure can. And Keegan got an appointment the same day, coming up pretty soon. And I think
July.
what we've got to come up with right now is a program. Have you had any type of genomic or genetic testing?
Yes, he had two sets. The first was called My Risk Genetic Testing, and it basically was testing him for the BRCA1 and BRCA2. It seemed like a waste. I didn't see anything about the prostate in that. And then I just want to correct, we were with Eisenhower all of 2023, but I myself, who worked there, was extremely displeased with how we were treated, and I kept asking, we need a bone biopsy, we need to, progress, and the oncologist was very lackadaisical. So he fired us, and we fired him in January of
Right.
2023.
So, I mean, I didn't finish off. I'm sorry. I should have said that it was recommended with whoever you're with right now that you start docetaxel, which I think he started. You were also using ivermectin and fenbendazole. You started Taxotere on June the 4th, 2025, and that he has TP53, but we don't know, is that somatic or germline? Or do you know?
I do not know.
Okay. So he should do the PROMISE study. We'll put a link in there just for the benefit. That will tell you whether that TP53 is germline or not. And I think I'll just have to check. I think that's on their panel. But the TP53 was all that came up. So the issue at this point is how to continue the treatment. The Taxotere is the protocol. Would sound right with that many Mets. Secondly, is he still on abiraterone and ADT?
No, they've stopped that.
Okay, well, the protocol would be right now for him to get the most would be triplet. So he should be getting ADT plus a second line anti-androgen plus docetaxel, if he can tolerate all of that.
Correct myself. He did have to get a Lupron shot in order to get the Taxotere.
Okay, so that would make sense, but I think you'll find Dr. Dorff will want to add something more. And the question also is whether she thinks there's any value to any radiation. When are you seeing Dr. Dorff?
July 17th.
Can you I would call them back and say, look, my husband's just started chemo. I'm not sure it's the right treatment. And, if you have any cancellations, can you give me a heads up?
Okay.
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 And see, because, that's fine if he's not progressing, but he's progressing. He's in pain. Yes. Mention that he's in pain as well. Be sure to mention he has bone pain. And I think that will grab her attention. John?
Thank you very much, Rick. That got us through a lot of stuff in a short amount of time. What I'm hoping is that a couple of chemotherapy treatments will reduce the bone pain and will be able to get you to a good GU medical oncologist. Get on a second line anti-androgen drug, even if it's back on the Casodex or maybe something a little bit better, and get things moving.
And we'd also add that we don't see any value at all in the fenbendazole or the ivermectin.
Yes, I'm glad you mentioned that, Rick.
Other than what it's costing you. Better to give us that money and than to spend it on ivermectin and fenbendazole. I know there's a lot of people on the internet who are promoting it, but it just doesn't have background. It's been shown to be effective in a single human cell taken out of context, not in vivo. It ain't there. It just ain't there.
Okay.
I've got a raised hand from David.
Just wanted to comment, Keegan, a good summary, and thank you everyone for the time you're given to Keegan. And she's an RN and looking after Ken. Is it my understanding, Keegan, that you got some ADT, but then you found out that he was, is it castrate resistant?
Resistant, yes.
So that apparently he got some chemo that he didn't need, because had they double checked, he was castrate resistant. So am I saying that, Rick and John? I'm not sure if I'm saying that.
No,
what that means is that while he was on maybe the Lupron and the bicalutamide, he developed additional metastases and the cancer progressed. So somebody probably used that to define him as castrate resistant. Nevertheless, when you continue on treatments after somebody develops that level, you still continue the ADT, you still continue the hormone treatment, because there's, generally speaking, a mix of cells in there, and you don't want to let go.
Right. And chemotherapy is appropriate.
Perfectly appropriate.
Thank you for that clarification.
Yeah.
Thank you.
So the question is, would anybody have any thoughts or input for Keegan? I think we're all anxious to know what happens when she sees Dr. Dorff, because she's just outstanding. I think she'll get this all straightened out. His treatment to date's been a bit of a mishmash, but he's on the way. The only thing I can say is, if we can pull it forward, we really need to pull it forward. See what you can do, and if you can't get anywhere, let us know, and we'll see what we can do.
Thank you, Rick.
Okay, thank you. I will.
Thank you for coming in. I hope that Ken feels well enough to step in himself for part of the group next week, and we'll see how the story goes. We'll make sure things keep on advancing all through the summer, okay?
Okay, and just to let you know, and anybody else, the group next week's on a Monday. It'll be Monday at 5 o'clock Pacific, 8 o'clock Eastern. Monday groups are always at 8 o'clock Eastern. Tuesday groups are always at 6 o'clock. We are going to have to monkey around with our Tuesday schedule in July. I think we know where we're going, but we'll let you all know, because it's a witching month. So we've got to switch our meetings around so we don't have 2 meetings on following nights. But just keep an eye on the reminder. It'll be there and clear.
So for your new guys, I'm going to go back to the regulars now and see how people are doing who wanted to catch us up or ask new questions. Bruce, I've got you on my list next. Did you want to bring anything else up?
Well, last night I raised the point that I've had now my second recurrence, and my PSA went up to 2.0, and I was started on Orgovyx, by Dr. Stish at the Mayo Clinic. That dropped the PSA to 0.2, which made him very happy. And I have 4, I guess you call them lesions, I would call them tumors, still on the prostate, still confined to the prostate, and the I think it's the left seminal vesicule. And I'm scheduled for a cryoablation to be done on August 1st at the Mayo Clinic. And it's your recommendation, and I will try to see what I can do about that, to have a consult with Dr. Heath at the Mayo Clinic.
You don't have an appointment with her yet, right?
Correct.
Now, did you just last
Can I
week-
just add, if you can't get to Dr. Heath, Dr. Sartor is a very, very good substitute. So you can go for either or.
Also at the Mayo Clinic?
Yes, Sartor, Oliver Sartor.
All right, Sartor.
Yeah, he'd be fantastic. So I just clarify, your last PSA was 0.2 or 0.53? Very last one.
It was, my last PSA was taken at the Mayo Clinic a couple of weeks ago, and it was 0.2.
Oh, okay. Excellent.
Prior to that time, I had a PSA taken down here. Oh, that would have been May or so. No, not May, April or so. And it was 0.5.
Now, you had a Gleason score of 5+4, and you had extracapsular extension. And you expressed some uncertainty about whether there might even have been some lymph node involvement. And yet you're going correct. And yet you're going for focal therapy. Is that all?
Yeah, because it was what had happened is that I had proton beam radiation when it was first discovered. So that would have been January through April of 2018. And I was started on Lupron in late November, early December of 2017. And it was Dr. Stish's belief the nodule looked possibly like it could be involved. I don't know which nodule, but he irradiated it anyway. And I've had a couple of PET scans and PSMAs since then, and nothing has shown up either in the lymph system or in the bones.
So that's why you're figuring you might have a focal problem? Just a local...
What do you mean by focal problem? The fact that there's these 4 lesions in what's left of the prostate?
Right. You're going to try to have focal therapy and obliterate these 4 lesions with a partial treatment of your prostate gland? Am I getting that right?
I guess that's what's going on, yeah. You seem somewhat surprised and even incredulous about that.
I think you're reading me correctly. I'm just worried that focal treatment of your prostate will be adequate, and I can't wait to hear. I hope you get an opinion from Dr. Heath. It sounds like the more recent PSMA scans have made things look a lot smaller and more easily treatable.
From what I understand of so far I've only communicated with Dr. Stish.
Right.
From what I understand, that is correct. His one concern, and right now the guy that's supposed to do the cryoablation is concerned that one of the lesions is close to the rectum.
Okay.
And they're very worried about what happens if, frankly, I guess I'd go on a colostomy or something like that.
Can I get any more comments from people? I do see a hand raised. I don't know who it is. Oh, Alfredo, thank you.
Yeah, Alfredo. I might have missed it because I had to step out of the room for a second. But Bruce, I just want to ask, has no one discussed just having a prostatectomy at this time? Why are we going after these 4 nodules rather than the whole gland?
No one has raised that.
Huh. Okay. The other thing I'll comment, many people here know this, but you might not, Bruce, is that they have now these, there's 2 products, Barrigel and what's the other one called? Spacor, which creates a little barrier between the rectum and the prostate. They inject it. It eventually, months later, gets absorbed by the body, but it gives you an extra centimeter of space between the 2. And I would definitely want you to ask somebody about that. You go in one day, you have this injection, creates the space, and maybe the cryo-ologist will feel more comfortable if that spacer is in there.
The doctor, I'm trying to think of his name now. It's very close to a city in Wisconsin. I'm gonna Woodrum is the doctor's name. He did talk about using a. I'm familiar with Spacor.
Okay.
From other patients and other groups that I've been with. I'm not familiar with the other one that you mentioned, but he did talk about injecting something that would increase the space, protect the rectum.
That's probably just what Dr. Alfredo was talking about.
Yeah, I would strongly urge you to for sure discuss it with the doctors. And as far as I could tell, when I had it done, there was no downside to this, other than the afternoon to go in and have the injection done. And by now, I'm sure I've had it resorbed by my body. But it just seems, from a simple engineering standpoint, oh yeah, let's put a little rubber grommet in there to space out the area we're worried about damaging. So I'd strongly urge you to explore that.
Well, this doctor did mention that. I don't know which one. He mentioned the medium they would use, but I can't remember what it was. But he did talk about that, yes.
Okay. Well, we plan to.
And by the way, he is. His assistant called me back after we had our phone call, and she was getting my permission, for him to discuss it with his other colleagues at the Mayo Clinic. She didn't name who the other colleagues were, and she didn't specifically mention if Dr. Heath would be involved in that. Although when I went up to the Mayo Clinic to get my most recent PSMA, I did mention Dr. Heath, and they said, well, she's a clinical oncologist and we're radiation oncologists. So,
yeah. So this again is the Mayo problem. They work in silos. They're very protective of their patients. They don't refer from one group to another. I have a feeling that's probably, I was not aware until Len just told us that Dr. Sato had left, but I have a strong suspicion that that was the problem. Not that he didn't know it, but I do know he thought he could change it because he told me. It's the culture at Rochester. Not true at Phoenix. I don't know about Jacksonville. But it's very, very difficult. So for you to get an appointment with Dr. Heath, Stish is going to tell you you don't need it. Why would you want to go there, etc., etc., etc. You are going to have to be absolutely insistent. I want this appointment. And it's unless you force you heard Daphne earlier on. You've really got to go in and advocate for yourself.
I personally, Bruce, I will personally feel better if you see Dr. Heath. I don't know about the rest of you guys. This is too fragmented for me, and I want somebody to pull this all together and get a little more aggressive with your treatment.
Bioprotect is another protector. Bioprotect is another thing like
the other thing that I think we would say is don't jump into any treatment, cryo or anything else, until you've seen Dr. Heath or a genitourinary medical oncologist somewhere.
Oh, jeez.
Okay.
I'm going to move on, Bruce. I have, and I am sorry about this, but I have about 11 people in a half an hour. So if anybody needs more time, either wait till next week or contact me and I can do some individual navigation during the week. I've got Steve Lodge next.
Yes, well, at Rick's encouragement, I did see a cardio-oncologist May 28th. They did a trans echocardiogram. In the med review, they didn't change any of my cancer meds. They did a couple changes on one heart med, and they suggested I change the statin I was on. But yeah, I'm glad I went through that. Gives me some confidence in the treatment I'm getting. My radiation treatment that I'm going through is going to complete next week. Sort of wondering what the typical follow-up is after that. I know they're planning on doing, after a few weeks of delay, 6 weeks to the first PSA, and then they plan to do a PSA every 4 weeks after. What other follow-up investigation should be done or would typically be done?
After radiation therapy, you have a medical oncologist also, right?
Yes.
So your medical oncologist will continue to do quarterly biochemical screening. Your radiation oncologist will probably see you every 6 months for a couple times to see if there are any extended side effects, GI or urinary side effects. And then after a while, if you're under good care, they'll probably let you go. I am very interested in the cardiac medicine change that was made. Could you tell me specifically you went from what to what?
Yeah, they went from metoprolol to
Carvedilol. Okay, yeah, okay. And that's the only change they made?
On the statin, they went from pravastatin to rosuvastatin.
Okay, that's I'm very interested. And who was the cardio-oncologist?
Marta Alhama Balato at the University of Washington Medical Center.
Thank you. Okay.
Would you recommend her if we have other people that need a cardio-onc at Hutch?
Yes, and she's willing to either take you on as a new patient, or in my situation, she suggested that I just use her for the adjustment and continue with my current cardiologist.
Okay. By the way, with rosuvastatin, you'll be happy to know you can eat grapefruit if you like grapefruit.
I do.
Like me, and I've got this enormous grapefruit tree outside my backyard, which Dr. John has seen. It's very important, so you're good with grapefruit. Dr. John, could you explain to us what the implication of that medicine change is for the heart? For the heart?
In terms of the drug interaction that Rick mentioned, there's an enzyme. There's enzymes in the liver that detoxify things in our body, and those enzymes can be influenced by grapefruit juice if the drug we're talking about happens to be metabolized by that enzyme. So with rosuvastatin, you're using a different enzyme in the liver to break it down, and you don't have to worry about the grapefruit juice. In terms of the rosuvastatin as a cancer issue, this is not a settled question, but are a couple of bits of evidence and a couple of people that feel that rosuvastatin has some anti-prostate cancer properties.
How about the heart drug, Dr. John?
Well, those are just blood pressure medication changes, and I don't think they have any implications as far as the cancer treatment is concerned.
Okay.
Hey, John, I read the same thing. Lipitor also has some questionable or possible, anti-prostate cancer effects. So I don't know if
Interesting.
it's solely whatever.
Okay, Jeff, quickly, and then
I
I'm
just
going to go on.
mentioned I switched from the exact opposite combination. The cord was causing me.
You're on twice, Jeff.
The cord was causing me a lot of problems, especially with acetaminophen. I was having really high pulse rates, and metoprolol, boy, just brought it right down. But it's just interesting that they should do the opposite of what worked well for me.
Yeah. Metoprolol will settle down your heart rate. Okay, thank you, Paul. What's on your mind, Paul?
Yeah, thank you so much. Real quickly, after my second Pluvicto, which I tolerated well, I was delighted to see my PSA went from 160 to 2. And
wow.
Yeah, wow. So I said that's remarkable, and I approached my radiation oncologist at the time of my third infusion with the idea that shouldn't I now get rescanned and perhaps quit while I'm ahead? And he was not particularly receptive to that idea. But I remember a couple of sessions ago, one or two of you had been in major centers where you had 3 Pluvictos, and then it was stopped because of an excellent response. So I'm just, this isn't terribly well written up in the literature. It's still, I guess, an approaching strategy. And I'll just say another issue that I find interesting and maybe useful is because of the avalanche of now pre-docetaxel patients seeking Pluvicto, they're going to start, rather than using an infusion, a 10-minute IV push. So that's another wrinkle in, we'll say, accelerating delivery. But anybody can feed back to me about a short course of Pluvicto 3 versus 4, 5, 6, because you've been evaluated with another PSMA PET, and the PSA is very low.
Other than stopping early for non-tolerance. Len?
Yes, I had heard that Dr. Antonarakis is one of the top oncologists in the country, prefers to follow a protocol similar to what you just mentioned, where he'll administer 2 infusions of Pluvicto, and if the patient responds well, he will stop there because the toxicity with Pluvicto tends, particularly the dry mouth and the salivary glands, get targeted by the third infusion. So yes, if Antonarakis is doing it, I put a lot of faith in that. There's science behind that.
Thank you.
How interesting. Okay, excellent to hear. Bob Schwartz.
Hold on.
Do I have a hand? Oh, I have a hand up. I missed it. Oh, it's Rick. It's Rick.
Important hand.
And I was observing protocol because my fratello observed protocol, and I was trying to be a very good boy.
And that's the hand that signs my paychecks.
You wish. You wish. I just want to say that it's what they call Dr. Paul, it's what they call in the trials physician's choice. We've seen, and one of the reasons that we've heard is because right now we don't know how difficult it will be to get a second round of Pluvicto on FDA on Medicare. We've had guys who have had more than one round of Pluvicto, but part of the Pluvicto they've had has been on trial. So they haven't had like 2 rounds off of Medicare. So some of the doctors are saying, well, you know, if you're doing well, why don't we keep a couple in our back pocket? We might be able to use them later on. And like Len, if it's good enough for Antanarachis and some of these other docs, it's good enough for us. Ben, what's your insight on this one? Definitely worth hearing.
Oh, exactly what you said. Yeah, exactly what you said.
So a quick question then, does Medicare, as far as your experience goes, and I'll have to look into it, kind of hold you in limbo land and for the time it takes to get 6 infusions? So, I mean, can you extend that over a year or 18 months, or is there some kind of drop dead date that says, well, you've gone past your first time around and now you're up for a second time and you're not going to be approved?
The best we can say is we think so, because I truly think this is new ground. I mean, you're not going to have a community oncologist in most cases, and I know where you're getting treated, and that might be a different situation, but most community oncologists are just going to go plow right through. They're not going to stop because they don't have the knowledge to know whether they should or they shouldn't. Now, in your case, yes, you've got a guy is very experienced. I think you're going to have a fight. You know, you might have to fight with him a little bit. Have you discussed it with him yet or not?
Yes. And he was hesitant.
And he was hesitant. Yeah, well, that we would expect that. On the other hand, if you were seeing Sartor or if you were seeing Michael Morris, they'd say, sure, yeah, you know, let's see how we go, and then you can come back. But we don't have the experience. Right. This is where I think you have to be your best advocate. I would be, if you would like, I think we can connect you to Dr. Antanarachis. I think. Because you carry the name. I hate to play the name card, but you do carry the name. So I'm sure maybe we can get Dr. Antanarachis to have a little chat with you.
You know, it's interesting just in his observation. So here I am. Heck, I know this has been my whole life, but I am a patient and I'm sitting in the chair and the white coat syndrome rears its ugly head.
Yeah.
And you would think, geez, if I can't have this very rapid communication with my treating doctor, I can feel for we'll say the civilians who are in the position.
Well,
and I applaud all of you here for pushing the envelope.
So, Dr. Paul, you go to our website, I'll put it in, and you need to get yourself an AnCan t-shirt that says, be your own best advocate. And when you go in to see him next time, you wear that t-shirt, okay?
I'll do it. Thanks.
Okay, I'm going to move on. We got a sailor here that's been waiting for a long time. Bob, would you bring up whatever you'd like to tell us?
Yes, thank you, Dr. John. Since I finished my chemo in May, I found out that I've lost a lot of body weight and muscle. And because of that, I don't know if the chemo causes it, but my legs seem to be really weak when I bend over to try and pick something up. It's a lot of energy and strength to try and get my legs back up off the ground. And I've noticed if I sit for periods of time, I get an ache or stiff lower back pain.
Well, I mean, unless there's something going on metabolically, something that could be picked up on a lab test, it sounds like you've been roughly deconditioned by your chemotherapy and have to attempt to recondition yourself.
I just wanted to make sure that. Thank you. And the last question I have is, I found out that I had some fluid in my lungs. Is that normal for going through chemo?
Bob, hold on a minute. Let's not just fly through this muscle issue, sarcoid, whatever they call it. First of all, Dr. Jack, would you like to chime in on how you get your muscles back into shape after a little chemo? Because there's word out there that you know a little bit about that one.
There is. Oh, I didn't know about the word. Well, I do know.
He's just thinking of sarcopenia.
I
Sarcopenia,
personally
yeah.
have had sarcopenia from my doublet therapy for 2 years, and I still don't have testosterone in my body after, being on a holiday for 12 weeks. But I do know the symptoms that's being described are identical to what I've been experiencing, which I've never had in my life, which is feeling I'm going to fall on my head when I bend down too fast to pick something up, because my legs feel very weak, weaker than they ever have. And, my arms and all my muscles are sarcopenic. And I have no remedy other than all the things I'm attempting to do, which is exercise as much as I can, have as much protein as I can possibly eat, and try and stay healthy and sleep and do all the other good things you're supposed to do to get yourself, feeling good, and hoping that whatever it is kicks in and I get my strength back. So I have no easy remedies, Rick, and I appreciate your confidence in me, but I don't really know anything that rapid that's going to magically turn around sarcopenia that's drug induced. And chemotherapy, I've had no experience personally with. I've only had doublet therapy.
So what, anybody else got anything they would like to contribute on sarcopenia? Whose hand is up? Somebody's. Oh, Lee Balin, is your hand up, Lee? You're muted. You've got to unmute, senor. Unmute. There you go.
Okay. It sounds like what I go through every time I get lazy and stay away from the gym for 2 or 3 weeks. You can't get up when you bend down, and you get low back pain after you sit in a chair for 45 minutes. And I will tell you, for the low back pain, back bends, a leg press machine, if you have a gym and it has one. If you don't have that, climb steps. If you live in a 2-story house, go up and down 5 times if you can. I've been sitting here doing curls with a 12-pound weight, and that's the only thing that's going to keep it going. Diet and exercise. You stop and you feel terrible. You start and you feel better. That's my piece.
God bless you. God bless you. That's we love that. We love that.
Just make sure, Bob, that sometimes we can leave chemotherapy with our red blood cells or our white blood cells or metabolic indices really out of whack, or even an infection. So make sure that those aren't the cause of your weakness. If they're not, and the chemotherapy's over and your cells are recovering, you should be able to rehabilitate yourself back to chemotherapy, pre-chemotherapy levels.
All right, thank you. I appreciate it. It's nice knowing that it is something that does happen, because at first you start thinking, well, the worst. Your head goes to that dark place, and I don't want to go there. And the other question I had was fluid in your lungs after chemo, normal?
No, I don't think so. Anybody? Where is it, in your lungs, or is it in the space between your lungs and your chest wall, or where is this fluid?
She said it was in the lower part of your lungs.
They said it was in the lower part of my lungs. They thought it was enough that they'd check on it, monitor. If next time I go, then I'd have to go see a lung doctor, I guess, to have it drawn out or whatever. I was just wondering. I'd never heard of it before.
Well, you had an X-ray, it sounds like, and you're going to have another one. Mm-hmm. So yes, if it's a considerable enough volume, then it certainly will rob you of energy, yes, and make it harder for you to breathe. What?
But that's as a result of chemo?
That I don't know.
Okay.
This is we're talking docetaxel, right?
Correct.
Okay. Maybe Len or somebody could look it up for us and see if docetaxel can cause pulmonary edema or, any fluid in the pleural
Yes,
space or anything?
John, I just did a quick and dirty Google search. It says docetaxel, a chemotherapy drug, can cause fluid accumulation in the lungs, also known as interstitial pneumonitis or interstitial lung disease. This, this fluid can manifest as pulmonary edema, pleural effusions, or other lung-related symptoms.
Yeah,
So
I
it's
think
real.
we've seen it occasionally during chemo. Dennis, did it happen to you?
Yes, I did. Pulmonary edema, both lungs. Put me in the hospital. Had to stay off the docetaxel for 2 weeks. Then I went back on about 60% dose for the rest of it.
Yeah.
All right, there you are, Bob.
Yeah, I vaguely remembered it. And Bob, one other quick thing, which is, I'm sure you will, but ease yourself back into the gym. The first time you go, if you do 5 minutes or 10 minutes, you're doing great. Don't push it. It's fine. You stay on that for a few days, and then you've got to ease back. Mr. Valens, you know about easing back into the gym, don't you? As I recall.
Yeah, well, I think you said eating. I weighed 249 pounds after a year of becoming an expert baker during COVID. Uh, I saw a doc who handed me a sheet on the Mediterranean diet, which is essentially lean protein, beans, whole grains, fruits, and vegetables. I weigh 173 pounds right now.
Good for you. Mark,
And when I'm a good boy, I go to the gym. My wife has to drag me sometimes. She swims 3 days a week.
Good.
I'm not nearly as conscientious as she is, but
Mark,
exercise is the key.
yeah, Mark, how did you ease back in for Bob?
Well, I tried to not do too much at once, but then I decided 20 minutes was okay, and that was too much. And really start smaller, shorter,
Yeah.
and then try that for like 3 times, and then add 5 minutes or something. But I did 20 minutes, and I was so sore I couldn't do anything for 5 days.
If you get short of breath, stop and catch your breath. I'm moving on.
All right, let me just say thank you to the group as usual. I appreciate all the information I received, and I'm very thankful. Thank you all. Thank you.
Okay. Jerry, we're finally going to get a catch up for you.
Okay, I'll try and make it real quick. I went off reclass, went to my osteoporosis doc, and he put me on Evente, and I'm due to have my 3rd shot tomorrow, and I'm not going to have it. What's happened is I've gotten some sort of an abscess in one of my molars, and I've got a huge lymph node that's ballooned off. So just kind of a heads up with these bone building drugs. I don't think I'm going to go on any of them. The one thing that the one that was suggested to me as a possibility was a small dose of Fosamax oral, not a shot. So now I did this to myself because I was on reclass for 6 years, and you're not supposed to be on it any longer than 5 years at the absolute most. So that's it. I don't know if anyone else has been on Evente. It's a new drug that's come out, and you can only be on it for a year. And I can't find out why you can only be on it for a year.
They don't want to increase the risk of a side effect in the jawbone.
Okay. Well, the effect on the jawbone came before a year even. So I've got to have an oral surgeon take out the molar and hope and pray that that'll take care of it. It's not a pretty picture.
And after there's a risk period after an extraction, so be followed up very carefully by experts.
Oh yes, I have a dentist that thank God he was interested in cancer and oncology, and he knows all about that. And actually, he could be the oral surgeon, but he didn't want to do it. So I've got a very good guy. But the other thing with the Avante is you get a rebound, and so you've got the rebound effect with it too after you stop. Not good. So that's it, John.
Okay. Thank you. John G.
Yeah.
Oh, wait. I got a couple hands. I see them this time. Keegan. What do you got, Keegan?
I just wanted to update you. I called Dr. Dorff's office. The schedulers were not available, but there is a ticket in for them to call me tomorrow so that I can get on the, up my appointment or get on the cancellation list as soon as possible.
Good job.
Okay. George.
Question: can a confirming biopsy be argued for intraductal? In other words, should I have a second biopsy?
You probably don't need a second biopsy, maybe a second reading on the same biopsy.
Well, I've done that already with Epstein, so I'm
Yeah.
good. Okay, thank you.
You can have a second. I mean, if a biopsy result really conflicts with all the other clinical and pathological evidence, I mean, we heard earlier in the group tonight of somebody that kept on repeatedly having benign biopsies despite apparent prostate cancer, obvious disease. And they kept on chasing it. It is certainly possible to have another biopsy, but it's an intrusive procedure, so you don't do it lightly.
Thank you.
John G. Are you still here, John G?
I'm here. Yeah, I just had to unmute there. Yeah, I just wanted to check in with everyone. I've been going through a radiation. I just finished it last week. 5 weeks of IMRT. My PSA is down to 0.3. I was at Gleason 9. I stayed at Hope Lodge. Just wanted to say that was an excellent experience. Really, really great place. Some amazing people there.
They paid for it. You didn't have to pay
for it. Yeah.
Okay.
It's more than that, though. It's just a lot of camaraderie and courageous people, and the staff there are dedicated. A lot of care. It's kind of an amazing place. So I finished my radiation. I'm back home. I kind of miss Hope Lodge. But
can't live there forever.
No, you can't live there forever. Somebody was joking that if assisted living is anything like this, I'm ready for it. Unfortunately, I don't think so. It's more like a resort kind of. It was an amazing experience. They had yoga classes, cooking lessons, pretty amazing. Anyway, I just want to check in because I've been out my wife finally figured out how to get me back online here. So I was saying that one thing I'm worried about is I'm having a lot of back problems. I'm like back pain. From what I'm hearing, it might be because I'm not exercising. So I guess I got to do that. Yeah, it's really hard I'm so tired. I'm like exhausted. If anybody has any, I don't know, ways to get past the tiredness to start exercising, any advice in that direction, I would appreciate it. And then also, I guess I got to follow up in, 3 months. They'll check the PSA again and then go from there. But if anybody has any advice about like how to get past the fatigue, I'd appreciate it. I just want to thank everybody for all the information.
Just before we get to the fatigue, how are you doing with your son? Have you gotten some help?
Yeah, I'm trying to reach out to him, trying to connect to him. You know, it's not easy. It's like I think I don't know. He's like he knows something's wrong, and I haven't been completely open about how bad things are. I mean, he knows I have cancer, but I don't think he knows how bad it is. But yeah, I'm working on it, and I appreciate that help too. Um, it's not easy. He's a teenager, so it's hard enough to begin with, and he's just all he cares about is video games. It's hard for me to like find common things to do with him. You know. I'm working at it, and I'm trying, you know, every day, or at least every few times a week. We don't live together, you know. He lives with his mom. But yeah, no, I'm working on that, and I appreciate your concern there, Rick. Appreciate that.
Well, we've got a couple of experts, and maybe they can connect you offline with some thoughts. But it is a concern for us because prostate cancer, like many cancers, but especially prostate cancer, is a family disease, and we forget about some of the people that come along. And we'd love to get you into Men Speaking Freely because that's a great forum.
I'm gonna try to do that. Yeah, now that I got my computer, or my wife's got my computer working, I can do it now.
And Dr. John or Dr. Jack, any pearls of wisdom?
I'm not even sure what the issue is. I didn't. What's going on with his son? This is the first I've heard of it.
It's just that, you know, I'm disconnected from him. You know, I have cancer. He doesn't really know how serious it is. He thinks it's just kind of minor, you know, prostate cancer. He doesn't. I have Gleason 9. I had a 27 PSA. You know, so I you know, just that I'm kind of estranged from him a little bit. I feel I don't know how to talk to him about stuff anymore. I think it's just a father-son thing. I think well, Men Speaking Freely might be the right group for that to address those things.
It's a complicated situation. I think it's something worth talking about at length. Maybe join the Speaking Freely group, and maybe we can get into it.
Yep, sounds good.
Yeah, and the other question I have is: have you switched your care? Are you going to be? Who's going to be looking after you going forward?
Yeah, that's a good question. Moffitt's going to get 2 new, supposedly GU medical oncologists in August. So one's at Dr. Jonathan Liu, and the other one, the person didn't know the name. So I'm going to look up how good they are and stuff like that. But I still think maybe I might have to, like Busich down in Miami might be the place to go. But so I have not changed. My radiation oncologist, he says, you know, he's going to follow up in 3 months, and we'll look at the PSA then. He thinks it's, you know, he gives me some statistic like, 83% chance you're not going to need any more treatment for 8 years. And I'm like, yeah, and 97% of statistics are made up on the spot. I didn't say that. So that's how I felt. But, you know, he was kind of reassuring, but, you know, I'm a bit of a pessimist.
Okay, well, Dr. Jack's also an expert on Dr. Belusic, so we can help you there too.
All right, sounds great.
He's very good.
I got 3 hands up, but I also have some people I'd like to get to. I want to, Alan, in your case, could you write to me instead this week instead of presenting and then write to me. We'll catch up this week, and then we will talk a little bit more in next week's group.
For sure, Dr. John. When is the meeting again next week? On Monday?
Monday at 8 p.m. Eastern.
Okay, perfect. I'll do that. Thank you very much.
And let's see what Bob Schwartz has to say. Bob not here. I thought he had a hand up. Okay. Oh, I see. People are taking their hands down, aren't they?
I know. What it was is I just wanted to say I went to Moffitt, and I'll be honest with you, I was very disappointed with it in Tampa. So I would look elsewhere. I really would. I'd recommend going somewhere else.
Okay, thank you.
That's such important information, and that's why we love these peer groups, because you're not hearing it even from us, but you're hearing it from people who had experience there, John. So.
Yeah, it's a like a bit of a factor. You're a bit of a number. It's tough.
Well, not only that, they messed up my medicine getting it to me on time, and they said it would be like a 14-day delay. And I said, I don't want to wait 14 days. Can't we rectify this? And they just put hurdles up. If you're going to Tampa, I would recommend somebody. I'm sure Len and Rick could go with me. Is Dr. Guanciale in Sarasota. If you don't want to go all the way to Miami, and I found she's been phenomenal.
Yeah, yeah, she's wonderful.
Joe Commander, would you catch us up with what's on your mind? Unmute.
This is going to be a little repetitious, so you can shut me up. First of all, I wanted to say that my doctor is a medical oncologist at Fox Chase, Dr. Pooja Gatalia, and she's wonderful. I've worked with her for 3 or 4 years now. She is on the fence, kind of, about doublet therapy. She's inclined to say I should do it. She wants me to know that if I don't do it, I'd be okay as well. This is her reasoning. So we're probably going to do that. I'm probably going to go on whatever it is, Nubeqa as the second line. I'm on Orgovix right now. Her reasoning is as follows: that when they did the tests for doublet therapy, the trials and so on, they were using less advanced imaging technology. So people who qualified for that test were more advanced than I am. That I would not have qualified for the test even back then. Therefore, we don't really know how it would work on me. Does that make any sense to you guys? It kind of does to me, but I don't know how to weigh it. I couldn't find anything written like that.
Well, I know what she's saying, but I don't see the logic. What she's saying is that when they first approved Nubeqa, it was a real flaw in that they used old T99 scanning. This was in the original approval. Now, I'm not sure on the new approval. Len, you may know, on the approval that they just got for the metastatic hormone sensitive. And by the way, I apologize, I didn't make that clear in the reminder, but the new approval last week was for metastatic hormone sensitive. Was it still based on T99 scanning?
Oh, I'm not sure about that. I think maybe it was.
Yeah.
So it was based on AirSense. Does that make sense to you?
Yeah, no, the question is, did AraSense use the T99 scanning? And we're not sure. But I think it's a red herring. I really think it's a red herring. I mean, I don't think that's the essence of the problem.
Okay.
I think the essence of the problem is you have recurrence. How serious is that recurrence? And the protocol for the recurrence that you have would include a doublet.
Okay.
If your doctor doesn't think you're worthy of a doublet, then you have to decide with your doctor. I think that if it were most of us...
She thinks that I asked her what she recommends, and she said she recommends that I go with the doublet. However, if I didn't, I'd still be okay. I don't know what that means, but
well, what it means is you should get a doublet, and I think that if it was any of us moderators, we'd get a doublet.
Okay. That's good enough. Thank you.
We have a handful of more people, and each of the remaining people said, I could wait next week. It's nothing pressing. Now, there is a group in this room at 5:30. I thought I was going to have to go at, well, for my time anyway, but on the half hour. I thought I was going to have to go, but people haven't come yet to pick me up. I think Rick and I can take a few more people, or but they're all optional ones. So shall we go on a little bit longer? Is that okay with people? Okay.
Let's keep knocking off the questions as long as we can.
Peter Monaco said if there's time, he'd like to bring up something.
Yeah. Hey, John. Yeah, I just wanted to give an update. I had a PSMA scan last week, and it came back pretty good, basically clear, as compared to one I had in May of last year. I spoke to my doctor, Dr. Patel, about it. You may recall that I had spot radiation at my paratracheal last September. It was a little tricky getting to the spot, but it looks like it hit the mark, and this lymph node that was on my paratracheal went from an SUV of 47 to an SUV of 3.9.
Good shot.
Tells me that that's insignificant, and that
Good shot. Yeah.
that's really not any real uptake any longer. And he was very happy with this result, and I'm going to continue on a monotherapy of Nubeqa. So I just wanted to give you that update that it seems to be going pretty well.
Fantastic. Very good.
We love
Was
it.
there any debate about monotherapy versus ADT versus both?
Well, I had been on Zytiga and ADT for 3 years, starting in 2021, and it was in May of last year that Dr. Patel thought I should take a break from that. My PSA had been undetectable all along, so he said, let's switch to a monotherapy approach to give me a little bit of a break.
Oh, okay. So
And
Doc's
at that
idea.
time, to set a benchmark, he said, let's do a PSMA test now and see what we got. And what we found was, again, there was this lymph node in the paratracheal that was still lighting up last year. The prior test that I had 3 years prior to that, an Aspen scan, showed not only that lymph node, but several bone mets along my spine. They have all gone away, and now the lymph node on the paratracheal is now, I guess, gone. And I'm on monotherapy, feeling much better on just Nubeqa.
No,
So,
you didn't get any gynecomastia from being on the Nubeqa alone?
what is? I don't even know what that is, John.
I'm sorry, breast enlargement?
I think I'm getting that. I think I've had it from the Zytiga as well, and on ADT. I think it started happening then.
Okay.
So,
right.
Doing my best to minimize it. I've lost about 27 pounds in the last year. For whatever good that's doing, I just feel better.
So
being lighter.
a couple of things, Peter. One is you can talk to your doc about getting a couple of shots of radiation to your chest. It does work, and better to do it sooner rather than later. When did you start the monotherapy, Nubeqa?
A year ago, Rick, last May.
Okay, so you've been on it all this time through.
Yes.
Okay. So yeah, I would just ask Patel, do you think a couple of shots would help me since I'm staying on the Nubeqa?
Okay, yeah, we did talk about that, about staying on the Nubeqa as opposed to taking a drug holiday. I'm not ready for that. I'm going to hang in there. Not like our colleague Len. I'm not as courageous as he is. So I'm going to
You're
stay
foolish.
on.
It might be too late for the radiation, but it's worth asking, I think, for sure.
Okay. Yeah, I didn't even think of that.
It can stop it from getting any worse.
Uh-huh.
but
Okay.
it won't diminish it.
Then I will definitely inquire about that because I've got it. I've got those signs of enlarged breasts. I know I do. But that started with the ADT years ago. So,
Yeah, it does. It can do for some people.
yeah.
I've got a hand up from Phil. What's on your mind, Phil?
Well, for me, I didn't have anything really to say for a year, so I finishing up a year. I started with a 4.9 Gleason, and the guy said, what do you want to do? And I told him I want to live. Ballistic is great, by the way, for those that were curious. I really didn't see him except the alpha and omega, the first and the last, but I went through 5 chemos. He said, you'll give it a try. And the 5th one, I had some problems with. I hit a 100.4 and I had to go to the emergency room. And of all things, my doc had given me stuff for upper respiratory, but in the hospital, they treated me for pneumonia and hurt my kidney. But other than that, he says at the end of almost a year that, and I don't understand the terms, instead of, I was saying, I can't find remission, but I found partial response, and he told me I'm closer to complete response. So we're going to go from the 3 down to the 2, the Nubeqa and the Eligard, whatever it is, Lupron. So here we go. We go to 2, but chemo was some fatigue, but other than that, I had no real problems. I think maybe I got a little dizzy once in a while, not dizzy, but a little bit slow in thinking. I played duplicate bridge online, and I wasn't scoring in the 70s or the 60s. It dropped for a while, but it's back now. I have my problem holding up and exercise. I have a hamstring that I need to go on, but I'm going to start the therapy on that. But I feel much, much, much better now. And the PSA that you look at, I don't know what undetectable is. Mine is running around 0.04 to 0.06. That's me.
Okay. Thank you. Is Ed still here? Okay. Is Alan still here? Babcock?
No, he left.
Okay. Is RJ still here? I saw him just recently. Let's see. There he is.
Yep, I'm here.
Go ahead.
So, quick update on mine is, let's see, last week I went to go see the medical oncologist and then also the surgeon. And so this is the medical oncologist, Dr. Zhao at Swedish. And so he said the metastases that I have, he would classify as low volume. So he went through the PSMA PET scan with me and he said, well, there's this one that would show up on a bone scan. These other 2 are definitely metastases. And then there's a couple kind of like very faint things that he said, all told, that's probably low volume because even the bright one was really tiny. So he said, probably the doublet therapy. So he said the Orgovix that he would try for. He said sometimes it takes a couple of weeks with insurance, and then either the Nubeqa or the abiraterone. He said that plus he said this is de novo, so you should get local radiation and then also radiation on these metastases. They will go do that. And then he said, you talk to the surgeon, you also qualify for this trial to still get the surgery if you want it. He said, if you want it, you can get the surgery. I mean, certainly, it's a randomized trial, so maybe you don't get it, but you can shoot for it. But he said, if you're not having problems, severe problems with urinating, he said, I wouldn't do it. And then I went and I talked to the surgeon, and of course the surgeon said, no, you definitely want to do this. You've got a lot of cancer. And you did say the guy that would do the surgery is Dr. Porter. So He's, I guess, if you're going to get a prostatectomy, he's the guy in Seattle to get it from. And so I'm just kind of debating with that, but more than anything, I'm just going to go see Dr. Schweitzer. And he said, I know who he is. He is an awesome guy. There's a set of, you are a medical oncologist at Fred Hutch, and get back to me when you talk to them. And so I'm in a little bit of a holding pattern here. My appointment with Dr. Schweitzer is 2 weeks from today.
Okay. Okay.
So what I would say on all of this, sorry, John, but we've got to get out the room very, very quickly.
Yes.
What I would say on all of this is listen to what Schweitzer has to say. I think it'll be a different take. Yes, we would always recommend treating the primary. The question is, when would we treat it? Would we treat it now? Would we treat it later? If you need docetaxel before or after? These are all questions that you got to ask Dr. Schweitzer. And that's it. So, you've just got to verify all of this with Schweitzer. Again, they're pushing clinical trials when we don't really need clinical trials here because everything's available to you. You can ask for surgery if that's what you feel you want, but it's got to be a discussion between you and your doc. You can ask for radiation between you and your doc, or you can go doublet, triplet, and do some radiation later, which a bunch of these guys have done. So
good, thank you.
And okay, I want to say, Dr. John, you're amazing. I don't know how you got through everything, but you did, and you're great. He's a wizard, right, Len? Oh, is Len still here? Len just left.
Well, thanks for keeping things moving for me, especially that one incident, Rick. That's a wrap, guys. I'll see you next week. Okay.
Thank you.
Thanks everybody for coming.
Thank you, gentlemen.
Pleasure. Bye.